so there's that. So I really appreciate the opportunity this morning to spend a little bit of time with you, and I have a goal. And the goal, and what I'm going to talk about, is actually right at the tail end of my discussion. So that's kind of setting the stage. The slides, I am from Texas, by the way. We're working on some really cool things in Texas. I think that's why you asked me to spend some time with you. The problem is when the horse stops, it falls, and we haven't figured out exactly. So I'm worried because I see some of you looking like, that's not real, is it? Another cup of coffee. So just as a total aside, it reminded me on my flight in from Texas 2 days ago, I'm on my flight. So this is, everyone has experienced this. And so I go back to the restroom, little TMI for your morning. I'm going back to the restroom and someone ahead of me has one of those nasty walking pneumonia kind of coughs. You've heard them before. It is like the wettest, it's like where's the suction kind of cough. You've all heard that before. And she's on my plane and I'm following her and she's going back to the restroom. So as I get to the back of the plane, standing in the back area, the flight attendant standing there and this like, just doing her coughing. And the flight attendant looks at me like, whew, and I just kind of whispered, I hope she doesn't die in there, just kind of as a joke. It was just a little subtle joke. Just a subtle joke. And so I said, so we're all going to get sick. And the flight attendant turned and she looked at me and she said, oh, hon, no, we won't. All these planes have HIPAA filters. So here's the deal. Here we are, right, in the medical business, and we don't have HIPAA filters on our aircraft. But American Airlines from Charlotte to Atlanta does have a HIPAA filter. So today's election day, right? Whatever the heck that means anymore. So I want to kind of frame what I'm going to talk about this morning in terms of election day. And when you think about election day, we elect people to whatever, do it all the time. And then a year later, or 2 months later, or 38 seconds later, we go, what the heck did we do? That's not what you said you were going to do. That's not what it was built, right? I'm going to turn that around a little bit. And I'm going to ask you a question. Did we get what we signed up for? Did you get what you signed up for when you chose a career, right? Everyone out there knows that. That first whiff of Jet A, right? Everyone knows that. Everybody feels it. We all have those memorable points. And you signed up and you said, I'm going to do this. So just like with election day, when you look back, I want to spend a little time looking back. And I'm going to ask you the question, did we get what we signed up for in this crazy world? So you made a choice. All of us made a choice. You could have done just about anything you wanted. But this crazy nut job room says, I think I want to go up in the air and go take care of sick and injured people. Okay, that's it. They're here from AV. Thank you all very much. We appreciate it. What am I doing? Oh, okay, sorry. But I think the mic, just kidding. I have to stay behind. I was in front of the white line. Apparently the structure of the front part of the stage isn't secure with my current weight. I'd go over there. Sorry about that. So we all made a choice. Aren't you glad you came this morning? We all made a choice in our profession. And we did it in an informed way. So you saw something, you experienced something, and you said, maybe more than most professions, you said, I want to do that. Not, hey, what do you want to do? I think I want to fly helicopters and, land at really nasty accidents. I might do that. Might get a business degree. No, it's all purposeful. And we made a choice for a reason. This is why I went into medicine. So you see all the ads, and it's like, well, I'm going to do that because everyone's happy. The nurses are happy. The patients are clean. The patients are happy. Everyone's smiling. The nurses and the doctors get along. The discharge instructions are a joy. So that's why I got into medicine. So did I really get what I was asking for? So I'm sure this is why you got into the flight world, because of that. And there's some of you out there that are looking, going, you know what, that's kind of sexist. So here we go, equal opportunity. I don't want any HR trouble here this morning. So, and of course, I'm sure most of you have those unique flight suits to get into the business, but it's like everybody's happy, everything's clean, everything's organized. I'm going to do this. So I know some things about you. Even though I don't know a lot of you, I know some things about us, actually. I've learned some things about our style, what we like, what drives us. You absolutely love what you do. Am I right on that? I'll ask you guys, do you love what you do? You love what you do. And when you look back, as my dad, the minister, would always say, you know, when you're on that big escalator and you're looking back, and then he'd say, now, whether you're going up or down, you're going to have to sort that out in your life. But what's important is you love what you do, and you do it better because of that. It's really a gift to love what we do, to not dread it, to go, oh, God, are you kidding? And we have our dreaded days, right? But you love what you do. And because you love what you do, you have to look a little bit, some of you are looking like, oh yeah, I work with that guy. So because you love what you do, I'm going to start building a story here. Because you love what you do, because we love what we do, sometimes we go a little bit farther in what we do than maybe other people would. You understand how small impacts big. Anybody ever put a gas grill together before? Yeah. So, you know, you put a gas grill together, that's a blast, by the way. And what is it? Home Depot's like $100. I'd pay $1,000 to put a gas grill together. It's like, never again. And you put everything together and you go, okay, there's Racht's gas grill. And you look in the box, and there's a bar with a hinge on it, and it's got some kind of valve on it. It's like, where does that go? Where did these last 3 nuts go? Where does that go? It's no big deal, it's just a gas grill. I mean, how bad could that be, burned in your backyard? But you know how little impacts big. You know how compression density impacts neurologically intact survival. You know how subtle changes in oxygenation, subtle changes in end-tidal CO2, subtle changes in physiology may be the harbinger of something that's really bad. You know the subtle differences when someone looks at you and says, I'm okay. You know what that means. It means I'm not okay and something's going on. There aren't a lot of professions that have that. Learning's important to you even when it's tough, even when it's hard to learn. All of us have had calls that have gone south, right? We've all had them. Of course, I like this, ha ha ha, Biff. Guess what? After we go to the drugstore and the post office, I'm going to the vets to get tutored. So we like to learn, and we learn sometimes from really, really bad events. So the aeromedical profession learns from its worst catastrophes, its worst patient outcomes. The entire profession turns around and builds those lessons learned into the future. Not every profession does that, and not every human wants to do that. You're tolerant. Yes, it was very loud, Mr. Trainer, but I said I wanted to hear your heart. So we're tolerant. Now, being in Atlanta, I lived in Atlanta for a while, and we have the tolerant terms, bless your heart. Aren't you precious, Kevin? Aren't you precious? Bless your heart. You have a keen sense of potential problems, right? There's not a lot of room in our world to miss something, to ignore something, all that little stuff I talked about. When we miss little, we may actually worsen big. So being observant, the subtle changes that you're able to pick up on and say, you know what? Stand by. That's not right. You enjoy problem solving under pressure. Matter of fact, I should change this slide. You don't just enjoy it, you love it, right? Because you get toned out. Let's say, doot, doot, medic 6, engine 5, respond to. Well, we've got Starflight responding to on the abdominal pain. Yippee, yippee. Which would you rather go to? An unknown medical that's hypotensive, or a nasty, disgusting multi-vehicle crash? Your choice. Who wants to go to the medical call? Raise your hand. I'm sorry, do you not hear me? Cool. Sorry, the dogs just ran out. Who wants to go to the crash? So that's my point. And that's not bad. So many would say, are you kidding me? A great hypotensive, maybe septic, rural nursing home call versus a multi-vehicle crash? Are you kidding? No. Because you love the challenge and you love the pressure stuff. We all do, right? What bothers others attracts you. So this kind of thing is like, oh, that's kind of cool. For us, to my neighbors, they're throwing up right now. It's like, oh my God, his arm is going, right? By the way, I don't know, have this slide for a long time. Nasty arm, clearly the guy has a pretty clean amputation of the arm. There's blood all over the grass. What the hell's the guy in the background filming? Excuse me, sir, the gross stuff's here. What are you filming? So when the alien spacecraft took off, he wanted to catch that. You have a keen ability to sort out when things just aren't right. You know sick and not sick, right? You learn it. If anyone's ever read the book Blink, it's a fascinating book. Blink says we are constantly building these databases in our mind with everything, right? So our pilot colleagues, your Blink database says, when I have an odd vibration, when I have an odd noise, when everyone else would be going, it's a noise for crying out loud. You know exactly what you're looking for and what you're going to do. So this profession has the ability to have this keen sense to sort out when something's not right. And here's what's key. Here's the deal. I specifically chose those words in italics. You sought out exciting care delivery in this environment because you could fly something else. You could fly the Grand Canyon. You could fly tourist helicopter. You could fly in New York, shuttle people around. You could work in an emergency department. You could work on a floor. You could work in a freestanding ED. You could work in a family physician's office. You could do IFT. But you chose this. You chose to ratchet it up to a different level. And I'm going to argue that there are very few, I'm like about ready to go through this line, and I'm sure one of these is like a trap door. Boom. And then, oh, you were going to come up, I'm going to get intubated, I'm going to have Foley's and stuff. And it's like, oh, that was a cool, what was that, 2019? Yeah, he fell off the stage. Yeah, we got to pulse back in like a minute. So you practice adventure medicine. And by adventure medicine, the physiology is the same, the anatomy is the same, the disease processes are the same. All of that's the same. But you chose to do it in an environment that's dramatically different. Dramatically different. It's like tactical medicine. It's like wilderness medicine. Physiology is the same. Anatomy is the same. But the way it's delivered is dramatically different. That's why so many people, if you look at emergency medicine residency programs, and the residents in the early days, remember the residents could fly, and then when it was you have to fly, there were residents that said, I'm not going to fly. Well, they've committed their career, right, to providing care to emergent need patients, but they said, I'm not going to do it there. I'll do it here in the ED, but I don't want to do it there. So this adventure medicine means you're different. You've chosen a way to do this differently. If you look at adventure, it's an exciting or noteworthy event that usually involves some degree of risk that's experienced firsthand, right? You don't have the same kind of an environment in the emergency. I don't remember my first day as an attending in the emergency department when Rob Hamilton and I worked together. I don't remember sitting in there going, okay, it's my first day. What do we got? What's out there in triage? What do we got? Okay. Hey, listen, why don't I go to triage, see what's coming in? How high is her fever? 99.2. Nice. What's go? Vomiting? Yes. Yes. Matter of fact, now that I think about it, I don't think I ever did that. Yeah, now, I'll tell you what, 100.7, those puppies are sick. So it's a different kind of an environment in a dramatically changing world. So when I ask us, did you get what you signed up for? Our world's changing on us. And I'm going to go through a couple things real quickly that I never, in my career, would have anticipated would have happened to me during my career. I found this 2 weeks ago, by the way, embarrassing clipping number 173. This was something in the Richmond Times-Dispatch a million years ago. In the fight for life, Dr. Ed Racht prepares an injection as rescuers perform CPR on Jerome McBride, who had been shot in the back. Let's stay and play with the injection for the gunshot wound to the back, because you can't get those folks too stabilized in the field, by God, before you transport them, right? So I look at that, and by the way, for those of you who are infection control little Nazis out there, yes, I am indeed pulling the cap off the IV with my, and I'll tell you what, that burns the sores in your mouth like horribly when you, but look at that. Look at that. There's a time where we felt that those patients' survival were directly impacted by our ability to establish IVs quickly, rapidly infuse volume, give them epinephrine, and today we manage that patient population so totally differently. All of us have put hang on. Is anyone in the room who's a clinician, never applied a pair of mass trousers? Anyone in here? Okay, get the hell out now. This is for your mom and dad and I to talk about for the rest of the time here. Yeah, see? The whole neighborhood's mad. Hey, as a total aside on mass trousers, there is some interesting exploration about the use, I'm not kidding, the use of masks during non-traumatic hyperperfusing events to actually shift blood volume from the distal extremities up to the core. So they're not totally, there's a bunch of you shaking your heads, I am not putting those back on anything. It's not going to happen. The miracle drugs, beryllium, isoprel, I can't even begin to tell you how many patients' lives we've saved with, miracle drugs like sodium bicarbonate and things. So we've done a lot. And then what we signed up for changed. I would have never imagined, ever in my world, that we were going to have a narcotic, a heroin and opiate epidemic in the U.S. Number one public health crisis currently, right now in the United States, is the opiate problem. By the way, clinicians are the major contributor to that. So this isn't just an illicit heroin problem. This is a narcotics problem, a prescribed narcotics problem. We know that it's substantial in several states. When you prescribe an opiate for a patient, you also have to make Narcan available to that patient. So when you have your root canal, you get the spray and you get the pills. We know it's prevalent. We know this. We know that in many states, and it'll soon be all 50 states, you can go into the drugstore and buy Narcan. Hey, got a big party this weekend? Yeah, going to Atlanta, AMTC. Oh, take some Narcan with you, man, because I'll tell you what, whew, you just got to be careful. Who would have believed that that would have happened? But there's more. So when you look, anybody know what this is? So this is a safe shoot center. This is a center that public health essentially says, we can't get to every single narcotic user, IV drug user, and say stop and be successful. But you know what we can do? We can provide a safe haven, clean needles, an observed environment, so if they do shoot, we monitor them there. And then just like at Disney World, where you do the rides and you leave and you have to go through the gift shop, when you leave, you go through counselors, social workers who try and continually get you into the right mix of a program to stop your opiate use. But there's more. There's heat mapping. So we know where we give Narcan. So this is actually one of our AMR ground practices. We know where we give Narcan. We work with law enforcement to say, hey, I'll tell you what, we are giving a boatload of Narcan behind the Walmart at Boulevard and Broad. A lot of Narcan. Maybe we ought to look at why that's happening. And this is what's important for us. What's important for us, so you see the mask, N100. So there's a lot of discussion about unintentional exposure to opiates. So you remember the Russian theater gassing. Remember that, the fentanyl gas in the Russian theater? So it is possible to aerosolize, to nebulize, to create an opiate that's strong enough, and we've seen that, strong enough so mucous membrane contact, it creates relatively immediate symptoms. So whether it's folly or not, our law enforcement colleagues have said if you're in certain areas, and gang, I'm getting close to that line again. Tell you what, can I get that Narcan real quick? My pupils are so small, I can't, sorry. So, yeah, now you're looking like that explains that whole thing. So our law enforcement colleagues would tell you that that's a force field, that if you try and get into wherever they are, poof, you just get a little puff of nebulized or powdered or aerosolized opiate that then creates respiratory depression, altered mental status. So there are discussions about whether all providers in the healthcare sector should be required to wear N100s when there is any risk of drug use, which essentially means from the time you wake up till the time you go to sleep, right? So at present, this is not a problem, but this should be big time on our radar screen in the flight world, right? Because we don't want anyone exposed to that in that particular environment. Anybody know who that is? Mrs. Racht, yeah, good guess there, sorry. So this is a Brazilian model who I think 5 years ago had progressive amputation, had an illness, progressive amputation of her fingers that went to the hands, that went to the arms, that went to the legs, and unfortunately died in a very short period of time. And the Brazilian media was, what the heck is this? How does that happen? She had what he had. Who's that? The Muppet guy, Jim the Muppet guy, who had and died from what he died from. Who's that? Superman Christopher Reeves, who died from the same thing she died from. Patty Duke, who died the same thing that he died from. What do they all die from? It's the thing we can't see, but it kills more people in hospitals than MI, significant trauma, and stroke. And it's a time-dependent, measured on a clock, not a calendar, it's a time-dependent killer. So it's sepsis. So sepsis, the new time-dependent emergency, and think about that in the environments that we live in, sepsis, the time-dependent emergency, has an extraordinarily high mortality rate. Here's the data. If you look at it, 29% of patients, this is several years old, but severe sepsis, a major killer. And what we do know is if you identify it quickly, administer fluid resuscitation, and secondarily, antibiotics, broad-spectrum antibiotics rapidly, you can dramatically decrease mortality. So, let's say I live way out in East Creation, and I'm septic, right? Our world, the air world, well, I'll ask the question. How many of you are being launched distance appropriate, being launched to a potential sepsis patient in your system? Sepsis, so a few of you. How crazy is that? I gotta tell you, Patty Duke would say it's not crazy, Christopher Reeves would say it's not crazy, the Brazilian model wouldn't. I would not say it's crazy. I want rapid intervention and I want rapid therapy to prevent that high mortality condition. So, South Carolina, the ground program in South Carolina is the first that I'm aware of that actually administers broad-spectrum antibiotics in the field. So presumed sepsis, broad-spectrum antibiotics are administered. There's still some debate, as many of you know, about blood cultures prior to administration of antibiotics. It's a whole new, time-dependent, high mortality disease process that we're understanding more about. I gotta tell you, just the literature on, and there's not a lot of it, the literature on administration of broad-spectrum antibiotics and dirty open fractures, something that we ought to be looking at in our patient populations. Who'd have thunk that sepsis would become that? Now look, here's the deal. I found this. I'm a pretty sharp doc. Home Depot, seriously. So if they're in septic shock, This stuff is outstanding. It's designed to treat septic shock. If you look on it, it's not, keep out of children's reach. Apparently this isn't the pediatric formulation of the stuff. I always like to be very clear, this is a joke slide. This is just kidding, JK, no, we don't give septic shock to, well, I mean, you could give it to your neighbors. And then there's this. Oh, come on. This is the air world rocked. We're not taking highly infectious disease patients, highly contagious patients. That's not our world. You remember this day? I vividly remember this day. I vividly remember Googling Ebola to figure out exactly, I'm sure it was a board's question somewhere, but it's a new, highly contagious infectious disease that hit our shores. And we had to very rapidly figure out what to do with that process to start moving patients. So most of these patients were moved by ground. So what if this exact same epidemic, this exact same outbreak was huge, large volume? Look what the feds did in the United States. The feds said, we are going to designate specialty centers because they need specialty care, and they're regional specialty centers, so they aren't close to each other. So as you know, Phoenix Air, our colleagues talk about adventure medicine. Phoenix Air moves these, fixed wing moves these highly contagious infectious disease patients. So you say, no biggie. I don't know if you've been reading the recent interesting literature and communication out of CDC and WHO, but measles infection has a unique impact on patients' immune system. It actually goes back and wipes out some of the immune response to other infections, something we've not seen before. By the way, this is one of our colleagues who transported. There were 3 of our colleagues that chose to transport patients in Dallas from Texas Presbyterian Hospital to Love Field, and they volunteered, and I saw one of our colleagues a year later, and he said, hey Ed, I want to show you something. And he shows me that, and I said, wow, why'd you do that? And he said, because I've been in EMS a long time. And he said, here's a disease that when you Google it, you see people bleeding out of their eyes, screaming in pain. Essentially, they die a hemorrhagic death. We were not real sure of mode of transmission at the time. As you remember, big question about simple respiratory transmission. And he said, I was really scared during that. I was aware of everything that was going on, all the calls I've had. I wanted to remember that because it was so powerful. Of course, I asked him, I said, hey, you single or married? He said, I'm single. I said, hey, listen, when you're handing a glass of wine, why don't you use your other hand? Yeah, use your other hand. Oh, look at the time, gotta run. Nice meeting you, bye-bye now. So, anybody know what this is? This is yours and my new Ebola. It's multi-drug resistant organism. So anybody transported any of these yet? Or been called? So get ready. So a multi-drug resistant organism is essentially a bacterium, a fungus, that there are no antibacterials or no antifungal agents to treat. And those patients are essentially infections that have no solution. So they go to highly specialized centers. We've transported an increasing number of these on the ground so far, and they're going to further and further away specialty centers. By the way, I'm not infectious disease, but I will tell you that 2 of the patients that we transported were being transported for chemotherapy. So remember, once a new bacterium enters our world, that bacterium will find its way to promulgate, survive, and live. So that's our new on the horizon component. Then there's this, OnStar. Sir, the police have recovered your stolen vehicle. Excellent, glad I have OnStar. Could you imagine this? No. Could you imagine Reach 52, Priority 1 motor vehicle crash, corner mile marker, I gotta make this stuff up, mile marker 722, 3.5 miles east of wherever it is, blah, 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 on a single vehicle rollover crash, high speed, one occupant, unrestrained, likely ejected, and no human being ever saw the crash? Could you imagine that? Could you imagine that if I'm in my Tahoe and I turn up the sound system, because there's some kind of cool song on that my daughter likes, so I turn the sound system up, and I'm the one that rolls, that my car knows I've done 2 circumferential rolls, I was going 72, and I dropped to 0 in 3.2 seconds. I have 2 right frontal impacts. I was wearing my seatbelt because the connection was there. There was a butt in my seat, so there was pressure there. When the car rested on its wheels, the pressure's still there, the seatbelt's still on. The data says the occupant is still in the seat. Could you imagine that? Is that possible? Absolutely. So our colleagues, Miami Ryder Trauma Center in Miami, Florida, there are a whole host of folks looking at automated dispatch of emergency services for things that are based on advanced automatic crash notification, the number of sensors that are in vehicles today. You know where the GPS is, so you know where the vehicle is. Could you imagine? Nah. Could you imagine your key fob has your medical information on it? So when you get in your car to drive and you have that little event, they say it appears that Ed Racht, a really muscular, healthy guy who is driving it, it appears that's who's driving, and here's what their medical history and their contact info is. Could you imagine that? Absolutely being worked on today. Could you imagine it notifies everyone you want it to notify? Could you imagine it calculates distance and says, based on where this event occurred that nobody saw anywhere, and based on the variables in the advanced automatic crash notification, we're going to launch an aircraft to that scene? Could you imagine that? Absolutely. Because you know how important time is in hemorrhagic trauma. So BMW has a countdown. So the device actually says, we are notifying, it's probably got a cool accent too. BMW's always had, hello, it looks like you've been in quite the accent, you've been in quite the accent with your accident. So you've been in quite the crash. We're going to call 911 in 10 seconds. We're going to call in 9, 8. We're going to call, you have to cancel it. If you don't, the device, the car thinks, you can't do that, you're not listening, I'm going to send emergency resources to your side. You know this, but you might not know how deeply involved this is. How many of you can let go of the steering wheel in your car on an interstate and it'll stay in the lines? Raise your hand. It yells at you when you go outside the lines, but it'll keep you in the lines. Your seat will vibrate if you get too close. You can do a setting that says, I want to stay just this far from the car ahead of me. So the technology now gives us the ability with radar, with sonar, it gives us the ability for our machines to activate us before humans are ever in the mix. And if you look at how expansive it is when you connect that to those patients that go to the OR or don't, based on the good old days of mechanism, this is very detailed mechanism data. I would have never imagined that. This was our first drone at AMR. It carries 17.2 pounds, and there's a defibrillator, two-way we have 16 of these, defibrillator, two-way camera. It's got 6 drugs. All of them are auto-injection for life-threatening. It's got a nebulizer with a small tank. It sits on the top of the ambulances, as you know. We are dispatched. GPS identifies where it should go. Pilot's notified. The pilot is piloting it. The person in the passenger seat in the ambulance has a headset, communicates when the drone lands with whoever the patient is or the bystander on the scene to walk them through what to do. I made that shit up. Is that possible? Is that possible? So, as all of you know, as the technology changes, so this particular drone delivered an IV bag of blood. We don't have a need to do blood for hospitals do blood. We don't need to do blood. Plus, it doesn't make a difference in the field. It makes a difference in the hospital, right? Anybody here from San Antonio or South Texas? So, you guys want blood? Absolutely. So, I'll show you something here in a second. If this is another one of our prototype drones that we're starting to explore in terms of care delivery and in terms of how they can enhance the emergency response system, whether that's fire suppression, hazard mitigation, or patient care. So, are you kidding me? Are you kidding me? Is that true or not? Did a drone really take a kidney for transplant to a patient in the hospital? Yes, it did. So to have the first organ for transplantation moved from the donor site to the recipient site is a dramatic wake-up call for us, right? It obviously dramatically changes how rapidly we can get organs to patients awaiting transport, good Lord. That's the olden days when we used to transport patients. Now we just bring the organs to you. Hey, we'll be right over. We got a kidney for you. So the reality is that world's changing dramatically. Not possible, right, Rob? Come on, not possible. Right? You guys know better than I. Not possible. Come on. Are you kidding me? Not possible. Really? Not possible. Our world is changing at light speed. All of what we do with patient management, patient access, whether it is unmanned, whether they are piloted, whether it's air, whether it's ground, how we get to them is changing dramatically. Is this what we signed up for? I'm not sure it's exactly that. Here's another thing I didn't sign up for. I didn't sign up for large-scale active shooter events in our communities. I didn't sign up for 1 October in Vegas when we were managing that scene. I remember in one of the debriefs, our colleagues in Las Vegas saying, we very quickly found out that when patients would approach us with blood, covered blood, and we'd start ripping a shirt off real quick to see where they were hit, we started to realize that the majority of those patients weren't hit. They were trying to help somebody else, so their blood was essentially the patient's blood. We know that we lost a number of patients who did exactly what we tell them to do. So if there's an active shooter at my kids' college, what do my kids do? Harrison, Brandon, Taylor, what do? You run. This audience participation here, by the way. My kids are in college, they know. Run, hide, and fight. So we'll never know the patients that we found after the event who were single patients, isolated in remote areas. Chances are they probably did what we're telling them to do. They probably ran and they hid and they hemorrhaged and they died. I would have never imagined we'd have to look back at run, hide, fight because we understand more. We understand more about large-scale events. I would have never imagined when the medical examiner told me that about 10% of the significant wounds that in her world were low entry, high exit wounds. And I remember looking saying, 32nd floor, that would be high entrance, low exit. Come on. She said, no, low entrance, high exit. What's that? It's a ricochet. I would have never imagined in our world when all of us are looking at what does personal protective equipment look like in the future, that you know what, anything that we do, we've got a whole nother segment of the body that we have to start thinking about in that environment. It's a totally different world. We know what works. We know about tourniquet use. We know the military's experience. We know how important hemorrhage control is. I wish I had just a little more time because I'd play you a video clip of our Las Vegas responders who went into 1 October. And during one segment of the clip, there is a woman that is screaming so loud, such a blood-curdling scream, episodically screaming. So my colleagues believe that she was having a wound packed. If you're in the military or you have military experience, you know what wound packing is. If you're in domestic civilian EMS, our wound management control is not the right approach. We dig, we push, we change the way we manage wounds. and it hurts a lot. It hurts a lot. So there are bleeding control kits. There are bleeding control kits in this building. There's now lyophilized plasma. Anyone flying with lyophilized plasma yet? Freeze-dried plasma? So a couple. So if you're not, my sense is that soon you will. So this is a reconstitutable plasma for blood volume. But are you kidding me? Did we get what we signed up for? University of Louisville is looking at freeze-dried oxygen-carrying blood. And look at the date on this, October, what is it, somewhere in there, whatever it is, I can't see, but it's somewhere like in October. This is a recent, was it Seth, help me? Yeah, it's the small pupils, I'm telling you. So we now are looking at freeze-dried, and the key there is storage controlled, right? That's a much easier product to store. Freeze-dried oxygen-carrying blood. Do you think that changes the aeromedical world for patients that are way out, patients that have rural, even significant suburban, or some kind of a barrier, significant injury? So our colleagues in San Antonio will tell you, Dave Miramontes, CJ Winkler, and his crew at University of Texas in San Antonio have essentially started not only flying, but putting whole blood on ambulances, even in short response intervals. And their initial data suggests a substantial difference, not only in survival, but in condition on arrival at the facility with transfusion of whole blood. So my colleagues from San Antonio back there, is that what you're seeing? Is that a yes? That's a like, I can't see anything, so if you said it. Corpus Christi, so it's part of the UTSA project, right? No, oh, sorry. Corpus Christi, that's South San Antonio, isn't it? Right, just, so, keep your eye on this. This is something that clearly is going to make a difference. So, 3 weeks ago, anybody flying ECMO patients right now? Yeah. Anybody flying CPR in progress now? Get dispatched, right? At Flight 7, Boulevard Broad, CPR in progress. Sorry, CPR, we don't do that. Nope, no CPR. Well, here's the deal. So ECMO, right? Extracorporeal membrane oxygenation. So ECMO, in its exploratory phases, may actually buy more time in an under or non-perfused patient to neurologically intact survival. So you say, all well and good, I just remember that nasty scene in the subway in Paris where they did field cannulation for ECMO. So, you know what, that's a ways down the road. Nope. 3 weeks ago, Albuquerque, New Mexico, did the first US-based 911 field cannulation of a patient who was placed on ECMO. So, is this what we signed up for? I don't remember that, because those patients were dead. I mean, you chose your mortality by where you lived, right? So the science is moving us forward. Oh, yeah, so here's the deal. We got into it for a reason. You chose it. It's changing. It's different. In some ways, it's better. In a lot of ways, it's harder. So did we get what we signed up for? Did you? I'm going to argue we did. Because one of the things about adventure medicine is we love when things change and when the challenge gets harder, because we want to get out there and bring order to people's chaos. I want to close with this. So adventure medicine, for all of us, has a cost. It is a blast. It is fun. It is fast-paced. It is intense. It is different than any other practice of medicine. And it takes a toll on us even when we say that it doesn't. Because I'll tell you, hey, I'll tell you what, you've been flying all week. That nasty wreck that you chose over the stroke patient. So I'm bringing my buddies up here. The humans aren't my buddies, just for the record. So it takes a toll on us. Every single one of you out there has been in an environment where a child didn't survive, or you've had to tell a parent in a motor vehicle crash, we're not transporting your child, and you're trying to figure out, do I say because she didn't survive, or do I just make something up and move them? Every one of us looks back and says, I could have, I should have, I wonder if I should have. And over time, that becomes a demon for us, because if I ask you, if I ask all of you, if I say, hey, Jen, does this stuff wear you down? Are you like wigged out by it? You're gonna say, it's what I do. Every one of us would say it. It's what I do. Suck it up, buttercup. Come on. Save lives. That's a business we're in. But when I'm alone, I hear music. I don't know if you do, but when I'm alone, I hear music. That's the dogs do that. This is a colleague of mine from Detroit Fire. He says, I wish my mind could forget what my eyes have seen. The demon we have is a demon that says all this adventure medicine, all this stuff, it takes a toll on us. And if we say it doesn't, we're lying to ourselves. As human beings, you don't like to see what happens to other human beings. And when you add the adventure and the adrenaline into it, it becomes a bigger challenge. More firefighters committed suicide in 2017 than died in the line of duty. There's a new concept floating around that some of my colleagues have helped me understand called the loneliness epidemic, where people who run into scenarios like this say, I'm alone. I can't tell anyone. I can't tell someone, I don't want to go to another pediatric heart arrest. I don't want to go to Boulevard and Broad anymore. I don't want to do it. I can't see that anymore. We know that there's a physiology associated with stress, and we know about post-traumatic, and I put this in parentheses specifically, stress disorder. This is Mopac Boulevard and William Cannon in Austin, Texas. 20 plus years ago, I responded to a call at this intersection. The call was a T-bone collision. It was an SUV and a sedan. I was the first on scene. That was my problem. Medical director should never be first on scene. And there were 4 people in the sedan, 1 person in the SUV. SUV was fine, she was on her phone. 4 people in the sedan, I did my assessment. Mom was screaming, crying, had some lacerations. There was a 10-year-old kid in the front. There was a 14-year-old girl in the back, and there was a 9-year-old unconscious girl by the post that pinned her in the back seat. I didn't have turnout gear on. I grabbed a bag valve mask into my head. All I said was, if I can just support her ventilations just enough, we were far enough out at that period of time, just enough, rescue alarm, air transport, get her to the hospital. If I can just support that, I'm here, she's got a pulse, I'm ventilating, I'm in the back of a car. I'm in the back of the car. I went through that whole process, and I kept doing the thing I tell everybody not to do, we all do. It's like you take your fingers down, so you're feeling a pulse, you got the hand on the mask, feeling a pulse. It's like the multitasking it's wrong to do. I remember she lost her pulse. I remember looking out at the captain on the engine company and asking, how long till we could extricate her? He said something like 10 minutes. I remember thinking, I wonder if I could do compressions against the seat. I've had a little science training. Are you kidding me? Compressions against the seat? The next thing I remember seeing is I looked out the back window at William Cannon Boulevard, Mopac, and Starflight had landed. And Starflight had the 14-year-old girl who was right there on a backboard loading her into the helicopter. I don't remember they're extricating her. I don't remember any of that happening. What did I have? I had tunnel vision. So that little girl passed away from her injuries. Everyone else in the car survived and did well. Every time I pass, I know it's small, William Cannon and Mopac Boulevard, I see that little thing of flowers right there. And every time I say, oh, I'm Mr. like strong guy here, just like talking about it. 20 years ago, I think, you know what? Could I have managed that differently? Could I have done it different? And then I start thinking the dumb thoughts, like how old would 9 years be today? It's like, why do I think about that stuff? So We have challenges, we have approaches, we have our own baggage. There are some principles that guide us, but I'm gonna ask three things. There are three things with PTSD of yesteryear, and I would argue time to go away, that you and I can do so that we do a better job at what we do. Quit calling it PTSD. When you leave this room, don't ever call it post-traumatic stress disorder again. It's not a disorder, it's an injury. It's an injury from the world we're in. The adventure medicine says we're fast, it's high acuity, and sometimes we get injured by a 9-year-old little girl at Mopac William Cannon. We do heroic things, but don't call us heroes. Because if you call me a hero, I'm gonna have those expectations that I have to be perfect every single time. And I've learned that from my colleagues that I work with. We don't call ourselves heroes. We do a lot of heroic things, but don't raise the expectation that we're gonna do it every single time. Because in the reality, when it does happen that we don't, it's gonna stick with us for a long time. And the strong raise their hands. And whether you're a leader or whether you're someone that suffers, hey, Ted, I'm wigging out. Of course you know, I'm wigging out. I think I need some help. Don't put me on light duty, send me to the quote shrink, tell me I'm doing whatever, help me. The strong raise their hand. The strong say, hey, I'll tell you what, this stuff's kind of eating me up. I wonder if you can help me with that. So I hope what I've done, and by the way, this is Bodhi and Sadie. If you haven't met Bodhi and Sadie, and they're training their humans right now, Lauren and Bobby, these have been one of the most amazing components of our healing time in areas that we're in. If you haven't spent time with either of them, congratulations to Bodhi, because I guess Sadie got fixed because she's had 27 kids. Yeah, so 27 kids. Most of you had a few less than 27, but extraordinarily helpful. Did we get what we wanted? I would argue it's time for us to go, do we have what we want? So let's make all those changes. Let's keep up with what's going on. Let's continue to grow. Let's do the fun stuff. Let's see what blood does. Let's see what we're going to do in the new world of emerging infectious diseases, because there is a big change on our horizon in what we're doing. So I appreciate a ton. I appreciate a ton spending time with you this morning. Thank you so much for what you do, for how you do it. I appreciate the privilege of talking to you. Enjoy the rest of the time. Thank you.